John is a very busy practitioner, and if you talk about passion, he has it. And he also is a very engaging speaker, and actually his hobby is comedy. So if he's not doing arthroscopy, he's doing imitations of people like me, and it's great. And he's passionate about the shoulder, so you'll see it. Okay, John?
Thanks, Scott. And I'm actually, I have a disclosure to make. I didn't take my meds, so I want to let that be sure. And I'm passionate. I'm passionate about Penn. I've been in the area since '84, and I had the blessing of training here. And good leaders create good cultures, and I just can't tell you how happy I've been since I've been at Penn, being surrounded by such good people. And the paradigm when I was a resident was high in research, clinical, marginal. Every guy, every woman that I work with are superb surgeons. I would literally send my family to each one of, as we say in Philly, use guys. Dr. Levin and Dr. Sennett, our vice chair, in addition to being, I think, very, very skilled clinicians, they're just great people. And I have a very, very warm and fuzzy feeling when I go to work knowing that when I go to Scott for a problem, he's going to give me the honest answer, and he's really going to do the right thing. And what else could you ask for in leadership? So I'm just a blessed man. So what's new in arthroscopic surgery, which is really the essence of sports medicine? And I have an internal medicine primary care bias. I thought long and hard about being a primary care physician. I just love people. I have a sort of a non-invasive tilt, but I love surgery. And it's such an interesting environment here to be around so many real doctors. Dr. Kapoor is a real doctor, and he also is a very superb sports medicine physician. And I love going to him with my medical problems. In fact, the other day I said, Raul, my cholesterol now is 230. What do I do if it gets any higher? He said, sell. And people don't know what the orthopedic, well, we know, I use a stethoscope once in a while just to look professional. Did anyone know what the orthopedic point of auscultation is? Anyone? The xiphoid process. We can hear the lungs, sort of. I hear a heartbeat and bowel sounds. So there you go. That's how an orthopedist. We have some celebrities right next to Raul's left is the famous track star, Jackie Joyner-Kersee. Jackie, please stand up, please. And to her left is Beyonce, who's out for a new album next month. So we're going to talk about knee-preserving innovations, jumper's knee, problem shoulder instability, irreparable cuff tears, elbow arthroscopy. So you're hearing a lot about scope. I have a lot of passion about minimally invasive, holistic surgery. If we do an ACL, it's not a free ride. Morbidity does exist. All these things can happen. I think that Mother Nature, I call it the good Lord, gave us an ACL with proprioceptive fibers for a reason. In the old days, we take everything out, put a graft in, make a big notchplasty, use bone, patella bone, hamstrings. And I think we really were making our patients become arthritis machines for those reasons. And we take out that graft, we also denervate the knee. The ACL provides a significant proprioceptive function. We all know proprioception is knowing where your body is in space. So I said, why are we doing this? The gold standard was the patella tendon. We know that quad weakness, there's a great rheumatologist named Kenneth Brand. Anyone familiar with his work? That maybe quad weakness is a harbinger of knee OA. Why is that? Anybody have an idea why that could be? What's your greatest shock absorber of the knee? Your quadriceps. So if your quads are weak, it's like having poor shocks in a car. Your car wears out faster. And I know that people who have a bone harvest have quad weakness. And there's actually a very, very talented fellow named Leo Pinchusky from Australia who has written about 8-9 year follow-up of bone patients getting not patellofemoral, but knee arthritis. I said, what's wrong with this picture? See, no one's ever proven that ACL reconstruction prevents arthritis. And I think these are some of the reasons why. Hamstring's a big operation, as you see out there. And these are good surgeries, don't get me wrong. But if you want to do it, and this is what Penn's all about, trying to push the bar. What's the absolute best? People like Dave Steinberg actually spend time in the laboratory. Dave operates on rats. And we're trying to figure out what's the best thing we can do for our patients. It's a blessing being an Irish, great passion. If I see something that's out there that I think is better for the patient, I'm going to learn that. I don't want doing something that's, B minus. I want to do what's best. And my wife's a saint for putting up with that persistence. Women are more hamstring persistent than men. They rely on their hamstrings. So if you harvest a hamstring from a woman, you're doing that woman a disservice. Do you know that if you cut an ACL or have an ACL division knee, you put that person on a treadmill and get an EMG, they have increased firing of their hamstrings? It's a compensatory mechanism. Why would you harvest the hamstrings? Denervation. Proprioception, we talked about that. Notchplasty. If you do a notchplasty in a dog, you give him arthritis, period. It's been shown in dog studies. Holistic ACL is really by respecting anatomy, respecting biology. Dr. Levin is a master at respect. He operated me once. He got me out of trouble one day, and I just watched the way he handles tissue. Good surgeons respect biology. I tell the residents, I want you to develop one thing in Spanish, say mano suave, means soft hands. You can't take good care of patients when you're slashing. I also mentioned Joanne Epstein. She's got a heck of a job. I have something called ADHD. That's attention deficit. That's a nice dress you have on, ma'am. So I'm never going to win any awards in coding and dictation, okay? So she puts up with that, but I'm working on it. Holistic ACL is really respecting biology. I don't like notchplasties, like reserving native anatomy, minimal soft tissue resection, and I think that you can use an allograft if it's not treated very, very stringently. It's almost as good as your own tissue. And I think you can preserve proprioception, less inflammation. And there's all this talk about double bundle ACL. Did you know that 80% of ACLs are done by people who do 10 or less a year? So if my job is to promote science, do I want to preach a technique that people are doing 10 a year, a double bundle ACL? Hello, that's hard for me to do. And I've been doing knee arthroscopy for 20 years now. So I think the spirit of science is, how can I help the audience? Let's get a reproducible technique that most community orthopods can do. Let's promote that. The Koreans have been ahead of the curve in terms of biology. We know that if we keep the PCL, for instance, and don't take it out and just drill through it, MRIs look better at a year. I took this logic to the ACL. And we also know from Pittsburgh studies that God tells you where to put the graft. There's our footprint right there. Isn't it funny, Scott, the older we get, the more you just go back. And Dr. Steinberg, my mentor, Dave's father, told me, we call it circular orthopedics. We go back to what we learned 20, 30 years ago. And people were doing this probably 20 years ago. Then we went back to this isometry thing, double bundle. Now we're like, hey, let's just put the graft where God made it. Hello, McFly. So here's the footprints of the ligament. We can reproduce that. We have a happy patient. So I use non-irradiated allografts, tibial anterior. That means it's very, very minimally treated. I take the anatomic insertion. I keep the graft. I drill through it. I don't take it out. Makes the technique a little harder. And there is a learning curve, of course. So just basically here's just peeling it off. And the anatomy will show you where to put the graft. It'll show you where. And here's what we have looking at our footprint. I drilled a little hole right where the creator made it, right there. That's where my guy pin's going to go. There's the AM bundle, PL bundle, you want to say whatever you want to call them. I put it right smack in the middle. And I think that it's funny, the older we get, the more we keep it simple. And there's our finished product, or our guy pin, coming through the native ACL. There it is, keeping it. And there's our finished product, a cut of a sort of a hybridization of the graft and the old tissue. And if you put it right, you don't get problems with extension. Now, as Scott and David and I guess other speakers have mentioned, Craig, I think we have the best residents in the cosmos. And these young men and women not only are superb clinician scientists, they're great surgeons. And I have been so overwhelmed with my research interests. I say, well, let's look at this. 2 days later, here's the protocol. I'm working on the IRB and like, wow. It's amazing. I don't know where we're getting these people, but they're just like DNA marvels. I just can't believe. You look at their CVs. Not only the AOA and they've cured cancer, but they've been in the Peace Corps and they have support groups for minorities. It's just unbelievable where we're getting these young men and women. Amy Hers looked up some of our ACL studies, and what we've done is holistic. And these were actually with some irradiated Achilles, but we're actually doing quite well with holistic ACL in terms of the results. So we're getting about a 4% failure rate, which is very, very comparable to the autograft, and this is with some irradiated grafts. I've been happy to say, since I've been at Penn now 2 years, I can't think of a single failure since we've used non-irradiated tibialis anterior grafts. Incisions this big, go home, no notchplasty, no patella tendon harvest. So I feel like a very, very lucky man. My job and my passion is to keep people away from Craig Israelite, which is a kind of a funny thing to say, but I would send my family him. I send everyone that I can to him. He's absolutely just superb arthroplasty surgeon. And one of the things about his character is a couple times I've sent people to him, and I'm very conservative. And I see the patient, well, Dr. Israelite say, go see, he gave me another injection. It's always good to hear someone that surgery is the last resort. And Penn Medicine is not only about scientific method and pushing the bar, it's about the practice of ethical medicine. And I love what Scott said. I don't like marketing. I just like doing the right thing. That's the best marketing in the world, I think, doing the right thing. So dose response to increase contact stress in the knee. When you take out meniscus, the more you take out, the more Arthur. And a young lady there who works in North Philly, my North Philly patients when I was at Temple taught me the word for arthritis. And I said to one young man, or one older woman, man one day, I said, how are you doing, sir? How can I help you? And communication skills requires humility. How can I help you? Doctor, this was the answer. I had a visitor last night. Oh, yeah, who came and visited? Arthur. Arthur moved in and he brought his cousin, Ritus. Now, that's a Southern term, and I know exactly what he meant. And he said, you know, doctor, once Arthur moves in, he never leaves. There's no cure for arthritis. There isn't. So when the more meniscus we take out, the more Arthur we see. But a repaired meniscus is better than no meniscus. And we have these new wonderful fixators that the old traditional technique was inside-out suturing. Now we have these fixators where you actually can fix a meniscus through a little dinky arthroscopic incision. It's a wonderful, exciting feeling that you can fix cartilage injuries with minimal invasivity. It's all about the blood supply. And we try to get meniscus tears that are in this area, the peripheral third. If I see a tear in that area, you have to talk me out of fixing it because I know that a repaired meniscus is better than no meniscus. And there is no cure for Arthur. So we have to enhance blood supply. Platelets is a concept. We can talk all day about platelets. There's studies pro, studies con. I have a hard time, Joanna knows this, getting insurers to pay for the platelet-rich plasma. Ideally, I would love to use platelet-rich plasma in every knee scope. It's hard to get approval. The art of medicine is who to fix, who not to. This is a meniscus tear that I want you to meditate on, that you look at this, and it's not really quite peripheral third, but if a younger person, I'm going to fix this because with these fixators, and there's no invasiveness to it, minimally invasive to it, there's very little downside in at least fixing it, because if you get a partial repair is better than no repair. His thing is really exciting, gets my passion up. For years, we saw these extruded menisci on an MRI, and I can't tell you what Dr. Israelite said. I can't say that enough about too many MRIs. I have to respectfully disagree with some other comments about repeating MRIs in shoulders. I get MRIs when I see symptoms. I always ask, is this test going to change my management? If it doesn't, I don't get it. Some of our patients pay 20% out-of-pocket copays for MRs. So why would I want to repeat MRI every 6 months when I know they have to pay $200 or $300 when it's not going to change my management? They need a man scan, a woman scan. They don't need an MRI. They just, how are you feeling? This is hurting. Let's see your weakness. Is your weakness? If someone has a problem that's getting worse clinically and by strength, then I think I look at it more closely. But these are extruded menisci. And for years, we said, this is Arthur. We can't help that person. But now we know that if someone has relatively good joints preservation, this may be a meniscus root avulsion. It's extruded. It's extruded. So when God made menisci, he gave us these very, very strong horn attachments. If the horn is disrupted, you've lost what we call hoop stresses. That meniscus becomes ineffective. It's virtually the same thing as taking out the meniscus. Now, thanks to technology, we can actually fix these things, and you can diagnose them on MRs. You'll see this very, very subtle fluid level right at the horn junction, and you'll see extrusion. And on the sagittal, you actually see that it's displaced anteriorly on the sagittal. We can fix these now, provided there's not much arthritis. We can drill a hole through the tibia, and we can pass sutures through that. This is really not that difficult to do, and get this. And you'll see restoration of the anatomy. And this is a 37-year-old did an ACL and happened to notice her lateral meniscus her root was avulsed. This renders this ineffective. So she was heading towards Arthur very, very quickly. If you want to trash the knee, take out the lateral meniscus. About 70% of the lateral of the joint's reactive forces are conferred upon the lateral meniscus. So we were able to fix that in not too much time. I do use meniscal allografts. The consensus of literature is it's not exactly counterprotective, but it can help people with pain, effusions, and function. And if I can help someone with pain, swelling, and function, by golly, I'm going to do it. And we use bone plugs on the medial side. We use a bone trough on the lateral side. And again, my passion is to do a lot of these osteotomies. Now, Craig showed the lateral closing. I love doing the medial opening. If I have a allograft patient, someone who needs a meniscal transplant but has a little Arthur, I may unload that joint. Just to pause and reflect here. Does anyone know the life expectancy of a 50-year-old in this country? Doc, what do you think?
35 years.
33.1 years. So the longer you live, the longer you live. So I have a hard time recommending someone see Dr. Israelite when they're 50. I'll do this because he can revise that, and I give him quality of life. And as we know, you're always better with your own anatomy. Let's shift gears here. So I do a lot of osteotomies. If someone doesn't want a total knee, I will do an osteotomy and give them 10, 15 years of increased quality. Now, not everyone, but as Craig would say, they better point that finger on the inside or on the outside. If they put their hand on their knee, then they have a little patella issue, and I won't do that. Jumper's knee is something we see in athletes, and this gets my Irish up. For years, the treatment was open debridement. Look at the pathology. It's deep. So you say to yourself, why would you want to open and strip the tendon of its vascularity when the problem is deep? So there is something we think that may be involved with impingement. A distal patella rubs against the patellar tendon. And actually, I started thinking about this, and you look at these CT scans of patella, and look at this. So if the problem is on the undersurface, let's treat it arthroscopically. Let's not open the knee. I had the blessing of treating this professional basketball player the other day, and I did this one knee, and his agent got involved, and he saw this big sports guy. He did his other knee, opened his knee, and I'm saying, why is he doing that? Because it's causing more pain, it's devascularizing the tendon, and it's not really addressing the problem. So this is a arthroscopic picture actually taking out the distal pole of the patella, almost like we do a distal clavicle excision, and you're treating the tendon surface inside out. The patients go home the same day, and they're walking within 2-3 weeks. It's amazing, their first visit. I actually wrote this up last year, or this year, and I found out that Dr. Bassett from Duke had this sign called the Bassett sign. You press on the patellar tendon, it's tender. 8 out of my 9 patients at early follow-up had no tenderness, sometimes as early as a week out. It's amazing when you take out those painful fibers. My passion is arthroscopic treatment of pretty much all joints. Shoulder is one of my real strong interests. I have a special interest in keeping people out of open surgery, and the problem with the shoulder instability, dislocator, is if they dislocate enough, they'll get bone loss. And the recurrence rate jumps from 4% to 67% if they've lost enough bone with recurrent dislocations. When the ball and socket joint goes out, you can lose bone on the humerus, you can lose bone on the socket. So that's a real problem. And this is what we see in the humerus. This is called a Hill-Sachs lesion. This is called glenoid bone loss. So usually we would open these patients and do elaborate surgeries. You'll see these bone defects commonly, and they usually occur in the front around 230 to 420, and 85% will have significant bone loss on the glenoid. So this is the gold standard open surgery, but look at this. There's the axillary nerve. This is subscapularis. Dr. Glazer eloquently described subscapularis morbidity with arthroplasty. You can also get it with open surgery. And also you can make these patients too tight and make it this. So you're not helping your patients. In fact, you look at the open Bankart literature long-term, there's an appreciable amount of arthritis 10, 15 years out. So that got my Irish up. I said, what can we do to help this a little better? And this is the other thing that really got me concerned. Dr. Sachs looked at the open Bankarts. 23% had incidence of subscapularis insufficiency. When you do an open Bankart, you cut this muscle, and guess what? It's never the same. I don't care who you talk to. If you're honest, it's never the same. Look at this atrophy on a sagittal MRI taken from Sachs' study. This is called fatty infiltration. And someone, the young man in the back, also talked about vitamin D. There was actually a recent study looking at serum vitamin D levels and fatty infiltration of the cuff. Vitamin D is becoming the new wonder drug, so I give my patients lots of vitamin D. How can we treat the problem with the bone loss? Well, I dabbled with this allograft arthroscopic. We got this published, and I said, it's hard to get the allograft. Let's go to the synthetic plugs. This got taken off the market. And then a colleague from California said, what happens when we fill that defect in the humerus with rotator cuff? It sounds very unphysiologic. It's called remplissage, done arthroscopically. I didn't believe this until I started trying this. Filling that big defect of bone with basically called tenodesing the infraspinatus. Dr. Nancy Major is a very, very productive radiologist that Dr. Levin knew from Duke, and she and I are collaborating with what happens to these patients long-term MRI-wise. And there may be some chondrometaplasia, maybe it fills them with cartilage. We don't know. All I know, or as we say in Philly, alls I know is the patients are happy. So the results, we have some residents that I don't know if they sleep or not. Dr. Park here is making us famous. He looked at our results, and he said that in follow-up of 24 months, only one patient reported instability episode. I think this has grown to maybe 3 now, but that sure as heck beats up that 67% number that we looked at earlier. He also looked at, he's going to present this this month at the Eastern Orthopedic. If we took the plugs that we were doing for a while, that the remplissage beats the plugs. So let's just ease into a couple other things. I have a passion for keeping people away from, and Dr. Glazer is extremely gifted arthroplasty surgeon. I watched him operate, and I would send my mom to him. But my goal is to keep patients away from him because it's a big operation. If you have a big cuff tear, what do? And I don't want a shoulder replacement. Well, the subscapularis is the biggest rotator cuff muscle. It's a humeral head depressor. All right? The trouble is, I think it's an old Chinese or Hebrew proverb that the eye sees what the mind knows. I love that expression. Subscapularis tears have seen you, but you haven't seen them. We didn't really recognize these arthroscopically for years and years. You haven't seen it, but it has seen you. There's a subscapularis tear. Diagnosed with the arthroscope because the tendon is intra-articular. All right, you would miss this open surgery. You would miss this fully. It turns out what Dr. Glazer said about the forced couples in the shoulder to resist the deltoid, all you need, or in Philly, all you need, is 1/2 the infraspinatus and the subscap. So I can take Aunt Millie sometimes, who doesn't want a new reverse, doesn't want a new shoulder. If I can fix the lower half of the infraspinatus and the subscapularis, I can sometimes take a patient who goes from here to here, and they're happy. So this is what gets my juices flowing, taking some of these debilitated patients who don't want a total shoulder. This is called a force couple. If we balance the forces, fix the subscap, the lower half of the infraspinatus, we can sometimes restore reasonably good kinematics. Lower half infraspinatus right here is the business end, and upper sub that resists upward migration of the humerus. And the suspension bridge concept holds true. Do you ever see a suspension bridge? There's only 2 anchor points, yet the bridge works. If we get the anchor point here and here reestablished, we can sometimes restore normal function in a shoulder. They're not going to be pitching for the Yankees, but they can elevate their arm, which makes my day happy. Now, the scope can make you see everything. And it took an Irish guy to figure this out. In 1945, he said, these cuff tears, they have a pattern. They belong here to here. They don't belong. When I was a resident even, they would take this tissue and put it here and put the patient in a sling and a splint, only for the splint to take off at 6 weeks to tear rip because we put it under tension. Dr. Levin knows this. People who know biology know this. The anathema of orthopedic surgery is avoid tension, whether it's in a wound or in a repair, ischemia. This is called margin convergence. We bring the tear edges together, put it back where God made it. If you know where it belongs, you can bring this limb to here. So some of these huge cue ball, we call it, you put the scope in, you see a cue ball, the humeral head. If you know where the tear belongs, you can put it back under minimal tension. And here's a patient with a huge tear. So we move this to this, we fix a subscap, and look, no dog ear means I guessed right, I put the limbs where they belong, and we got this puppy covered. Boy, did I feel good about that. Those are the kind of days you go home and light 3 candles. Thank you. I did this. Thank you for helping me. This is called the interval slide. You can do releases. If you know what the anatomy is, you can bring it back and get these puppies covered if you know where the tissue belongs. And you need the arthroscope. If you know where it belongs, you won't get a dog ear. And you'll at least get it, as Dr. Glazer said, partially covered and restoring the business end. Here, again, no dog ear means I guessed right. And with enough experience, you do. So you can do a partial cuff repair, get a force couple. Subscap tears are not recognized. In the infraspinatus, you get half it done. You can really help the patient. Don't forget, we do the AC joint resection. We smooth the acromion, take out the bursa. I think this is more pain relief. We actually looked up our series of just 14 patients with massive cuff tears. These are people that some people would have done reverse shoulders in, and they all had satisfaction. 13 out of 14 had good scores. They all had good pain relief. The weakness was present. We're going to finish up with elbow arthroscopy. If you see someone with loose bodies, tennis elbow, and I don't operate on tennis elbow very much. If you do more than 2 or 3 of these a year, you're probably doing too many. OCD, which is what I have. I wash my hands a lot. I have OCD and ADD. I could use a few more vowels. Throwers, Arthur, and epicondylitis. I love these cases of OCD of the capitellum. The throwers don't get better. See that little fluid level there? That means that this is unstable. This needs an operation. And this is Arthur of the elbow. Now, thank God we don't walk on our elbows. So if I can make some of these patients a little better and give them 10, 15 degrees of motion, they're happy campers. We can resect the coronoid. We can resect bone spurs with the scope. This is a 62-year-old guy I saw 3 months ago, and he was one of those Penn State alumni gymnasts, and he looked like he had stretch marks on his teeth, He could bench press the building, one of those guys, I'm talking about. He wore his wristwatch on his finger, And he said, Doc, I miss lifting. I can't get my arm straight. And we took off this spur, and this spur. We got his arm near straight, released the capsule. I called him. He's a real heavy hitter. He went back to Florida. Like I saw him one visit. He's already in Florida. I said, hey, how you doing? He goes, thank you. I lifted today for the first time in 6 months. I mean, how don't you feel good about yourself when you do this? With little dinky punctures. We can get appreciable motion increase. And if you have a refractory tennis elbow, and I do believe in injections, I do believe in platelets for this. We can talk about that again for hours. The tennis elbow, the ECRB, is intra-articular. It's right below the capsule. You can access it with an arthroscope. You can release it. And the blessing of the arthroscope for the elbow is that you have sometimes concomitant intra-articular pathology, loose body, and we call posterolateral plica. We'll see a little synovitis posterolaterally. Ankle arthroscopy, love it because you do primum non nocere, minimal incisions. We can do loose body synovitis, OCD again, and how about this one? Arthroscopic ankle fusion. Respecting soft tissue envelope, 2 dinky incisions. This is what we can take, this in the ankle. And I have a disclaimer, if it's significant deformity, I send it to Dr. Pedowitz, Dr. Wapner. But if it's minimal deformity, I love these cases because they go home the same day. And this is one of our Penn football coaches who actually coached me in college. What a blessing to operate one of your coaches. I saw him last week. I said to him, you help me because football coaches teach you about life. I said, I'm so happy that I can teach you or can help you. He walked in, he shook my hand and says, John, I can't thank you enough. I have no pain when I walk. Come on. If you don't, that's why I just love my job. We're going to finish up with hip arthroscopy. Labral tears, loose bodies, psoas impingement, rare, but it happens. And this is called cam pincer. When they get cam and pincer, that means they get too much bone on their femur or their acetabulum, which may cause arthur and have them see Dr. Israelite. If we can intervene sooner, maybe we can prevent that process or slow it down. Labral tears are a fact of life, and this is the art of medicine. I think most people have labral tears from just wear and tear. The question is, who needs an operation? And that's it takes a lot of, I think, skill, which I'm still on the learning curve. Bony impingement of the femoral head. That's impingement. You'll see this in the literature a lot. Either overgrowth of the acetabulum or too much bone on the femur. And if we resect that bone or resect this bone, we can actually, I think, make the patient feel better for a long time. We see this bump more in men. We see the pincer more likely in women, but most patients have elements of both. So if you get your x-ray, you'll see the anterior acetabulum cross over the posterior acetabulum. That's called a crossover time. That means they have either what we call acetabular retroversion or a little overgrowth here. And it's been shown that this overgrowth can actually lead to premature joint degeneration. This is called the cam lesion. You see it on a frog lateral. And I believe, and maybe people argue that this is a result of arthritis. I do think it's a cause of arthritis because there's some early literature now saying that if you take this bump off, the patients have satisfaction scores that exceed 2 years. This is called the impingement test. As Craig said very, very well a few minutes ago, groin pain is usually a hip process. If you rotate that leg internally and they have groin pain, they have impingement, and they probably need something done. That's my alarm saying I'm near the end here. And this is called psoas impingement. Do you like that trick, Scott? To keep the ADD in check. Psoas tendon can impinge, and you'll see someone with a snapping hip, and usually they get better with rehab. If they don't, we can release the psoas tendon very, very, not very easy, but readily with an arthroscope, and you can actually cure their problem. So the art of medicine, who needs a scope? Look for mechanical symptoms. That means clicking, catching, impingement sign, and this whole concept of sports hernia gets my Irish up because I think it's very rare. I think most patients have either a labral problem or a muscular problem that's not heated. So beware of we don't do hip arthroscopy for arthritis, just like in a knee. If there's a question, who needs an operation, give them lidocaine. If they get better with the lidocaine, an operation will help them. If they don't get better with the lidocaine, then I send them back to Dr. Kapoor, Dr. Plaskaris for some more rehab, whatever. Here's our setup, a lot of traction, and we actually can, believe it or not, now we can take out trochanteric bursa that aren't responsive to rehab. And one little last thought, beware of gluteus medius tendonitis. Gluteus medius is the greatest hip abductor muscle. So if someone has chronic lateral pain, as Craig indicated, and you keep injecting their bursa, they don't get better, think of gluteus medius tear or gluteus medius tendinosis. The gluteus medius is the rotator cuff. I'm talking about my mom now. My mom's like, my rotator cuff is killing me. When are they going to find out a cure? When are they? I say, Mom, you're talking to they. There's no cure, okay? So anyway, beware of someone with chronic trochanteric pain. It could be a gluteus medius tear, and we can take out the bursa arthroscopically, and actually we can repair the gluteus medius arthroscopically. So I want to thank you for your attention, and choose wisely. The arthroscope is God's gift, but choose wisely. Thank you.